Hello everyone, this is our Project Medic 8. So first, let's start with data wrangling and pre-processing. We started by removing non-informative features such as Z prior, which did not give us any useful information. And then we addressed the imbalance in CID using oversampling to reduce the bias. And then we used standardized numerical features so that the differences in scale did not affect the analysis. And then we also engineered features to capture the patient change over time. We calculated CD4 and CD8 from baseline to week 20. And then we calculated their ratios to measure the immune response directly. And coming to the demographic factors between the failure and the non-failure groups, we analyzed race, gender, and sexual orientation as a factors, and then we used two sample Z-tests for proportions to test for group differences. All three demographic variables showed statistically significant differences, and then the results describe patterns. It doesn't imply causation. Coming to the technical approach, we trained a random forest classifier with 200 trees and maximum depth of 10. The model approximately achieved 76% accuracy and then AUC of 0.71. The feature importance analysis identified CD4 and CD8 feature values at baseline and week 20 as the most influential features, and these results align with the general clinical understanding of HIV disease progression.
Okay, to evaluate the effectiveness of the treatments, we compare the CD4 and CD8 changes in ratio across our target outcome. So on the left, we can see that the count from the start to the end of the study, and there were relatively small changes for both classes, and the patients with CID1 tend to show slightly more negative CD4 changes, indicating weaker immune system. We also observed that there is a slightly bigger decrease in the mean CD8 counts in the class CID1. This could reflect natural variation in immune response among patients or other factors. So on the right, we can see that both classes show ratios that are predominantly below 1, and class 1 consistently maintains a lower CD4 to CD8 ratio than the class 0 at both start and the end. So looking at the immune response across all treatment groups, we see mixed results, but overall the treatment appear effective, and the mean CD4 counts increased while the mean CD8 counts decreased, indicating a positive immune response. The highest CD4 increase was seen in the ZDV plus DDI group, and the lowest CD8 change occurred in the ZDV plus ZAL group. The CD4 to CD8 ratio showed a small increase from before to after the treatment, although it remained below 1.
And to further compare the effectiveness between treatments, we use the Kaplan-Meier estimator, which is a gold standard for time event data like this one, which measures the probability of a patient to survive past day TI with significant differences between the curves by the log rank test. We can see that ZDV plus DDI has the best survival probability over time, and the ZDV only treatment is drastically lower. We also want to investigate the correlation between prior therapy and the Karnowski score, which is the functional score of the patient. Our initial hypothesis is with more therapy, patients should improve in functionality. However, data shows the opposite as seen from the lowering medians as score increases. Nevertheless, we found recent research that supports and goes deeper into explaining this phenomenon.
Our survival curves show treatment-naive patients survive at 79% versus 67% for those with extensive prior therapy. The log rank test confirms that this is highly significant as a p-value less than 0.05. This aligns with the published research in 2014 that drug resistance accumulates with treatment durations. Treatment-naive patients are the best intervention window. So why does this matter? With 38 million people live with HIV globally, our model identifies high-risk patients using basic lab values such as CD4 and CD8 available anywhere. In resources-limited settings, this enables efficient triage that scales resources to those who need them most. The same immune-based framework applies beyond HIV to pandemic response like COVID-19 or future threat. Thank you for listening.